Hi class, this is Larissa Lurken and welcome to my presentation on my scholarly project. So the title of my scholarly project is The Development of a Clinical Practice Change to Enhance Parental Understanding of Postoperative Pain Management. To start, I'd like to acknowledge my committee members. So my DMP chairperson for this project was Dr. Joanne Kern, and then the community member that I had, which was a resource actually at the organization where the scholarly project was implemented, was Miss Rhonda Cady. She is a clinical scientist in the research department at the organization. Background and significance of my project. The identified practice problem was a lack of standardized education concerning postoperative pain management, and this was specifically on an inpatient orthopedic surgical unit. We'll get a little bit more into the setting at a later slide, but that was the background of the problem, and this included multiple things. This included the content of the education, this included the timing of the education, and what methods are currently being utilized. So as it stands right now at the organization, there is no standardized education specifically about pain management. A lot of the education is simply provided verbally through whatever staff member is working that current day. And so families can get various amounts of education depending on which staff nurses are working that day. And as we all know, healthcare is becoming increasingly complex. There is literature out there that state about 77 million adults in the United States alone has limited health literacy, and included in that data is about 25% of parents that have low health literacy levels as well. As you can imagine, repercussions of these low health literacy levels are extensive. This includes multiple things. This includes an increase in medication errors. This includes a lack of engagement with the parents and the children themselves. Higher obesity rates, increased tobacco or alcohol-related behaviors are just some of those repercussions of low health literacy levels, specifically in parents. And then Harvey and Kowalski actually did a study and found that nurses and parents have very different expectations concerning postoperative pain and what comfort looks like for the hospitalized child. More specifically, parents feel that the child should be deeply medicated to the point of not feeling any pain whatsoever after orthopedic surgery, while the nurses expect the children to have controlled, intermittent, tolerable discomfort. So with these different expectations, I personally can see it where I'm working because I work on the unit where this project took place, and so it's very clear to see at times where these different expectations are. And quite simply put, there's no standardized method of assessing any patient-facing materials that we have, and so this project looks more into that. In terms of literature review, the PICO question that was designed was, do key stakeholders at a specialty pediatric organization find that the design of a newly developed educational video would be an understandable and actionable tool to inform patients and families about pain management as compared to the current standard practice? So this project was kind of a twofold design. So one was the design of an educational video, which I myself, the researcher, created, and the second part of this project was evaluation of that video, and this was done particularly by key stakeholders at the organization. In terms of literature review, multiple well-known databases were searched. This include PubMed, CINAHL, Medline, and more recent peer-reviewed articles between the years of 2016 to 2022. I looked at many articles surrounding what the design of a newly developed educational video about pain management would look like. And so given that this project consisted of developing that educational video, the question then eventually became, what are the ideal characteristics for such a video where understandability and actionability would be maximized? And after doing the literature review, about 3 themes emerged, and this included, first, the language of the content that was in the video, second, the use of pictures or animation, and then the final theme was the content, timing, and length of the video. So we will dive a little bit more into these. First, the language of content. Many articles suggested that you should use plain language and layperson terminology. Any medical jargon should be avoided as well to avoid any confusion with parents. And then the recommended reading level should be between a 6th to 8th grade level. Second theme was the use of pictures and animation. So multiple journal articles also suggested that visual aids improve patient outcomes, and this included things such as images, animation, as well as interactive elements. One study found that animations and icon-style concept art can actually spare viewers from graphic details of real-life clinical procedures, which is very interesting and important in pediatrics. Kids can sometimes be scared a little bit more easily with things that are going on. Simple things such as just seeing an IV in the arm can feel graphic to the children. And so any animations really helps to spare them from any sort of graphic or gory details, as well as the animations can also highlight very important details that may be overlooked if you are looking at a video depicting real-life clinical procedures. The third theme that emerged from this literature review in regards to creating the educational video was content timing and length of the video. So first, included in the content, what should be for sure talked about when discussing postoperative pain management. This includes standard postoperative care. This includes analgesic options. So the video touched a lot on pharmacological interventions as well as non-pharmacological interventions and how parents can, more specifically in the inpatient unit, use non-pharmacological options for pain management. This included things such as using ice packs, using distraction, repositioning frequently. And then the video also touched more specifically on how nurses can provide pharmacological pain management. However, educating the parents on what these medications typically are in this specific unit and what they're used for, any specific side effects, things like that were very important and touched on in the video. Also included in the content of such an educational video are coping skills, how and when to assess pain, and then how parents can help to report pain as well. For example, if the patient starts crying or they become restless, these are signs that potentially the pain is getting worse and they should consult with the nurses or the nursing assistants, anybody on the unit who can help them manage their child's pain. And then finally, content should include what goals are in the postoperative setting, specifically around pain management. Timing of the video is extremely important, and many articles found that providing the video on the day preceding surgery helps to reduce both patient and parent anxiety. This has been way more successful in reducing the anxiety as opposed to the heightened anxiety and stress that families and patients themselves may feel on the day of surgery. The theoretical framework that was used as a foundation for this project was Nola Pender's health promotion model. So this model explicitly involves activities that are aimed towards developing resources which not only maintain but can also enhance a person's general well-being. In essence, you can see a picture of what this health promotion model looks like, and there's the three key characteristics. Those are individual characteristics and experiences. There is behavior-specific cognitions and affect, and then finally behavioral outcome. You can see how they are all intertwined in that model there. In essence, living a healthy lifestyle, as described by Nola Pender, is mostly informed by an individual's biological, psychological, and sociocultural factors. Potentially they have a history of prior similar behaviors, and perceived self-judgment of their personal capacity to act. And then finally, living a healthy lifestyle can be informed by perceived benefits of actions or perceived consequences of actions as well. So this theoretical framework was used because this project aims to increase parental knowledge and that parents' perceived self-efficacy in carrying out the actions that are being described in the video. So hopefully that they can be more engaged with their child's pain management, which has many benefits to it. The method and design of this project was a quality improvement initiative. This was used because we have built on existing knowledge. It required no demographic data from the participants to answer the research question. So we decided to go with the QI initiative, which did not require IRB oversight. So we got approval through QI IRB from both Maryville and the facility as well. The data collection tool for this project was called the Patient Education Materials Assessment Tool, also known as PMAT, and it was specific for audiovisual materials because of the multimedia video that the researcher had created. This tool is a established and reliable tool in literature that can be used to assess forward-facing patient-facing materials. And I'll show you on the next slide what that PMAT looks like, but for this project, it was reformatted for ease into a Qualtrics survey. And so there are many statements it includes a bunch of agree and disagree statements, and there's two categories. There's one category for understandability, and there's one category for actionability. So essentially how understandable is the material and how actionable is the material. So not all of the statements applied to this particular project, and so there were 13 applicable agree-disagree statements for understandability, and then in a similar fashion, there was 4 applicable agree-disagree statements for actionability. The data was collected and scored then based on how many agree and disagree responses were recorded. And this was all done online for the participants, which made it much easier than using a printed tool, the printed copy of the PMAT tool. Scores were then compared to a predetermined benchmark of 80%. And this 80% was actually decided by the DMP chairperson and the researcher together. And then there was also some literature that was from the creator of the PMAT tool himself that suggested a minimum of 70% as being good quality to actually implement into clinical practice. For the sake of this project, the DMP chairperson and myself decided to set a goal of 80%, which we felt was good enough quality to finally be able to implement in practice. So this project was not actually... The video wasn't implemented, but the project was all about evaluating the video for potential implementation in the future. So you can see what the PMAT AV tool looks like. This slide is specifically for understandability. As you can see, it's pretty straightforward. The statements are listed there, and they are divided just into different categories. And then the participant who would be filling this out would essentially pick 0 for disagree and 1 for agree. So it was very easy to format into the Qualtrics survey where they either clicked agree or disagree, and then that subsequently gave a numerical value to it. So this would be a response for one person. And then as you can see at the bottom, you would take the total number of points that came from this participant and divide it by the total possible points, which for understandability would have been 13 for one participant. And then the second slide simply talks about the actionability score as well, very similar to the first category, but for the purpose of this, it was divided into 2 different categories, understandability and actionability. As you can see on the bottom there, this tool can be used by anyone. It doesn't require any training to identify and evaluate patient educational materials. So the sample for this project, as mentioned earlier, the setting was a children's hospital in the upper Midwest region of the United States. For quality purposes, the exact location and name of the organization was excluded from the survey. And then participants had a 4-week window. The Implementation of this project officially started on July 12th, 2023, and ended on August 9th, 2023. Data was collected at various points between there, which we will get into here in a second. The inclusion criteria for the participants was very minimal. They needed to be at least 18 years and above, which everyone at the organization is. They needed to either be a registered nurse, a medical doctor, or a nurse practitioner who was working with patients on the orthopedic surgical unit. And then finally, the participant needed to be able to understand both written and auditory English, given that the video had written words on there and then a voiceover as well. So there were 48 possible participants that would be included, and as you can see on the pie chart there's 27 registered nurses that are possible participants who fit the inclusion criteria. There are 20 medical doctors, and there is only one nurse practitioner. This equated to approximately 56% of RNs, 42% of MDs, and 2% NPs as possible respondents. As mentioned earlier, given that the survey respondents would remain anonymous, it would be unknown exactly as to what percentage of respondents specific to each category were participants. Analysis of the data, we decided to do a 1 proportion z-test for each category. So 1 proportion z-test was done for understandability, and then 1 proportion z-test was done for actionability. These were completely separate tests that were run. The z-test was decided to be performed because it's usually done when comparing two proportions between 2 groups. Typically, this includes one being an observed proportion and the other one being a hypothetical or theoretical one. For this project, you can see that the observed proportion would be the actual tangible data results that I collected. This would be the results from the tool that we just discussed. And then we would compare that to the hypothetical proportion, which would have been the 80% predetermined benchmark, as we talked about. There are minimal dependent factors. This was simply agree or disagree to the statements on the PMAT tool. And then the survey would therefore result in an individual score for each category. So for example, a response of agree to 10 out of 13 statements would give that individual a score of 76.9%, and say that's for understandability. These individual responses were all combined for understandability, and then they were combined for actionability. This allowed us to have a larger sample size and decrease the minimum number of participants required to get statistical significance. So subsequently, the scores that we got from the survey were compared to the 80% predetermined benchmark through the 1 proportion z-test. And this 1 proportion z-test was used to determine if there was statistically sufficient information to suggest that the understandability ratio was greater than 80%, and then actionability ratio was greater than 80%. And this was discussed by Dr. Pauls. The level of significance for this project was 0.05. Which essentially means that if we found that the results were statistically significant, then there would be less than a 5% chance that finding the results, less than a 5% chance that you'd find these results by chance alone. We ended up getting a total of 29 participants out of the possible 48 participants. So you take the total number of participants, 29, and multiply that by the possible statements of understandability, which would have been 377. Out of those, we got 368 total number of agree statements. So as you can see, this was a total of about 98% of people agreed that the content was understandable according to those statements. Likewise, actionability, there was a possible 116 statements, and we got 112 agree. So after completing the analysis using the 1 proportion z-test, the z-scores were found to be higher than the upper tail critical value. The p-value was found to be less than 0.0001, and we would reject the null hypothesis. You can see with this statistical analysis here for understandability, the level of significance was 0.05. There was 368 agree statements out of 377. After performing the calculations, the z-test ended up being a little over 8.5, and the p-value ended up being 0.0000, which we would reject the null hypothesis, which was 0.8. That also represented the 80% predetermined benchmark. So there was sufficient information to suggest that the understandability ratio was greater than 80%. Very similar actionability. The agree statements was 112 out of 116. Same null hypothesis, same level of significance. The z-test statistic ended up being about 4.5. P-value was also 0. We would reject the null hypothesis and say that there was sufficient information to suggest that the actionability ratio was greater than 80%. Limitations. Participants in this study were healthcare professionals with elevated levels of health literacy already. To minimize this limitation, participants were instructed to strictly fill out the survey based on the information in the video alone and not rely on their own prior existing knowledge. Additionally, some items on the PMAT AV did not apply, hence why there was only 13 applicable statements for understandability and 4 for actionability. Unfortunately, this did decrease the ability to further assess understandability and actionability. And then finally, unconscious bias could have been a limitation, knowing that the video was created by a coworker at the organization. To minimize this unconscious bias, the creator of the video remained anonymous. Discussion. The results of the project are sustainable, provided that the content within it does not change. Unfortunately, there is limited generalizability as it is currently produced. However, that can be generalizable if it is customized to the target organization. Barriers, lack of computer access. Some participants or possible participants did not have computer access at home, thus they had to complete it at work. And unfortunately, there were many days where people were busy and just simply didn't have time to complete the video and the survey. Another barrier was forgetfulness of the initial email. This was because the email was initially sent out and there was 0 follow-up reminders. There was a few staff meetings that reminded participants. However, that was only done for bedside nurses, and therefore nurse practitioners and medical doctors did not get reminders to finish that. Additional feedback, some suggested using internal photos from the organization. Some suggested including verbiage related to administering medication via the G-tube, and then also replacing the monotone robotic voice in the video with an engaging multi-tone voice was a suggestion. Implications for practice. Parents and guardians will better be able to understand how to manage their child's pain, thus creating action from their understanding and more active participation. Parental involvement will likely improve patient satisfaction and comfort and reduce time required of nurses to manage a child's pain. Access to the video allows parents and guardians to replay the instruction. This subsequently reduces the time that healthcare staff spend educating families. And then videos like this can be easily changed or modified should the information become outdated or inaccurate. Future research, I think we should implement this video into clinical practice to gather additional feedback from families. We can create various videos regarding different topics as well, and some of those examples are listed here. Finally, I just want to say that this QI initiative was successful. We were able to answer our PICO question and say that the video would be favorable in the clinical setting. The key stakeholders found that it was understandable and actionable to implement into practice, and this was demonstrated by the data analysis showing statistical significance. Further recommendations can be made to more thoroughly assess the video's impact on clinical practice. This includes how that impacts parent, patient, and staff satisfaction, as well as improving pain management. And any questions, feel free to reach out. Thank you guys very much for listening. Here are my references, and have a great day.